Hi, everyone. Thanks for having me today. I'm going to be discussing the role of fMRI in invasive mapping in clinical pediatrics. We have slides. Okay. So I have no disclosures, but these are the grants that have supported the work I'm going to present today. So reliable presurgical guides are necessary to predict and minimize adverse impact of surgery on cognitive functioning. And we heard a beautiful talk from Chris about one method to do that, which is language fMRI. Oh, we're going to go back. Oh, okay. Here we go. Which is language fMRI. We also can study memory this way, although that's still in development, more so than language. And then I'm going to briefly review subdural grid mapping, SEEG mapping, and try to think of all of this in the context of social cultural factors and other factors such as age, cognitive ability, and bilingualism. So we won't talk very much about language fMRI because he did a beautiful job. I refer you, as he did, to the Voets paper, the OHBM working group, showing that it is a very useful technique clinically. However, when you're working with kids, there are a lot of things that you need to be thinking about. The age and ability and the appropriateness of the stimuli. Do you want to use the same paradigm for everyone, which is good for research, or do you want to adapt the skill level, which is usually more necessary for clinical purposes? You want to think very carefully about the control condition, the developmental capacity of the person, so you don't want to give a reading task to a person who's not able to read at that level. So we're always trying to match. Clinically, I'm always looking at the neuropsychological evaluation to see about how the person's doing to decide what task to give. Similar with letter fluency or other frontal skills, executive functioning skills that may not have developed yet. Also pictures, a lot of people like to use pictures. We find with kids that passive viewing of pictures does not show robust activation, so just things to think about. And then do you want to do a covert, monitored, or overt task? So I think most of us would love to have people talking in the scanner, and I'm actually going to talk a little bit about that at the end. But for most of us in a clinical setting, the sequences we would need for that are not available, so you have to do more covert measures, which changes the cognitive processes involved. So you need to be aware of that. And also there may be some movement with the pushing of the buttons. We have many, many language tasks that we use, both research and clinically. I'm not going to go through all of them, but I'm happy to talk about them with people later. A lot of different pediatric hospitals are using them, which is great because I'm starting a pediatric consortium where we're sharing all this data, and that will eventually hopefully become Pediatric Enigma Epilepsy. I'm going to talk mainly right now about this one, which is our auditory description decision task. And that will kind of factor in a couple of the studies that I talk about today. For this, the individual hears a sentence that names an object, and it's either true or false. So an example that would be true is a red fruit is an apple. That's true, they push the button. An example of something that's not true is something you sit on is spaghetti. You can sit on spaghetti, but you're looking for chair there. So that would be that task. And then the control task is actually just the forward speech in reverse with tone decision. So they're pushing buttons in both the actual active condition and the control condition. It's all auditory and it's monitored. All of our tasks are 5 minutes each. They're all block design, and we have various levels depending on their ability. These are very common group level maps that we have for both our category decision task, listening to stories, reading, and then the one that I'm going to focus on today shows really nice frontotemporal activation. Interestingly, these are group level maps, but on an individual basis, we see very robust activation. And for this task specifically, it looks just like this. I didn't even believe in clinical fMRI until as a postdoc, I had to review hundreds and hundreds and hundreds of these, and they all looked the same. And the other thing that we think a lot about with kids is what do we expect their laterality to look up like? Chris talked a lot about laterality and laterality index. But what do we expect for kids? So Madison Burrell in my group published a paper in Human Brain Mapping in 2012 and looking at typically developing people with some of these language tasks and found that by 4 to 5, we're really seeing Broca's and Wernicke's and even some laterality, left lateralized Wernicke's and Broca's, but the strengthening of that happens over time, where we expect the temporal regions to be more strongly lateralized by 7, and the frontal not until about 10. So we're always factoring that in when we're thinking about this with kids. Of course, one cannot talk about language fMRI without thinking about factors such as bilingualism. This is a slide and a project from Elena Stasenko at UCSD, who I work with her mentor, Carrie McDonald. And what she was interested, were epilepsy people primarily, so she was interested to see how epilepsy modulates the plasticity of language networks in the first language versus the second language, and if the age of seizure onset interacts. So she looked at 24 bilinguals, 45 monolinguals, and 3 tasks, and then looked at a conjunction map. And she found that L2 and L1 are differentially modulated by the hemisphere of seizure, such that primarily in left temporal lobe epilepsy for L2, bilinguals were more bilateral than monolinguals. But the cool part for me, and where I kind of got involved in this project, is that it did vary by age of seizure onset. So for L2, this is specifically for L2, if your onset is in childhood for your seizures, you are much more likely to have a right lateralized pattern as an adult. For L2, if your onset is in adolescence, could be more bilateral or mixed. And if your onset is in adulthood, you're more likely to stay left. I should say this paper is coming out in PNES soon. I'm going to switch now to memory fMRI, which is actually what I mainly do. As many of you in the room know, the mesial temporal lobe is important in memory encoding retrieval. It's also important in generating seizures, which is one of the reasons I study epilepsy. And while we know that language fMRI is used clinically and thought to be reliable, memory fMRI is really not, especially with kids, and we're going to talk about why. There's important differences between kids and adults regarding memory and memory system, and in epilepsy, the majority of studies do not show presurgical lateralizing memory impairments for kids. For adults, you often see lateralizing memory impairments, but not for kids. And then what I think is most interesting is that actually their memory doesn't decline the way it does for adults. So if you take out a hippocampus in an adult, especially the left, you're likely to see a verbal memory deficit. Doesn't happen in kids. It may depend on the type of resection. There's some evidence that more mesial resections for kids may cause this problem, but there's still debate about that. Regardless, kids are having memory impairments, and they're feeling it in their academic achievement and health-related quality of life. It's one of the things clinically they complain about the most. So, if memory is so important, and many kids are reporting concern in this area, why aren't we studying it more? Or why aren't we using it clinically? Because it's hard. So I think a lot of you in this room know that designing paradigms that increase cerebral blood flow enough to detect the MTL signal is difficult because memory processing pathways are always online. It's difficult to assess retrieval in the scanner because we're often not having people talk, and I'm going to get to that. But we really do want to get at this retrieval and not recognition. The hippocampal structure itself is a tricky area to study because it's small and proximal to flow fields. For children, it's particularly tricky because all of you in the room are neuroscientists or related, and you're listening to these beautiful studies of memory functioning, and they have 250 to 300 stimuli, and the people are in there for 20 minutes, 30 minutes, and kids can't do that. It's too hard for them, especially our kids that have developmental disabilities, are lower functioning. So that's something to think about. And then these elegant tasks like the remember no paradigms are very difficult for kids. So what do you do? One of the approaches that we've taken in the epilepsy world, and I would credit Binder with sort of maybe starting this, is that he found that language fMRI, which we know is reliable, can predict memory in TLE adults. So we wanted to look at our auditory description decision task, the one I keep referring to, with the statements that name an object, and we wanted to look at that in kids and adults with epilepsy. And what we found is that the majority of individuals did show MTL activation, so here I'm saying hippocampal and parahippocampal activation in this language task, but what was the most interesting to me is that there was a main effect of age, such that adults were more left, and you could see that both in terms, so this is the adult group here, you could see that both in terms of their mean LI, so remember more positive LI is more left from what Chris said, but also in terms of their peak voxels, so more peaks on the left than the right. And then for kids, their mean was hanging out more in the bilateral range, but actually what we were seeing was that some were left, some were right, and some were bilateral. It was a mix. And for adults, the laterality of the MTL was related to language laterality, but not for kids. So this suggests a developmental shift in MTL lateralization with increased left lateralization across the age span, and may explain why children have better memory outcomes following resection than adults, because they could use either hippocampus or both. Some groups are using direct memory measures clinically. One group I know of is a Seattle group, and they published a paper in 2022. They used like kind of a derivation of the hometown walking task, and they found bilateral mesiotemporal lobe activation for this task, and it was greater contralateral to the temporal lobe pathology in an epilepsy cohort. What I think was most compelling is that a follow-up study by their surgeon, Hannah Goldstein, showed that in those that declined in memory after surgery, if they had overlap between this activation and the surgical resection, they were more likely to show a decline. So 6 declined, 5 out of the 6 had overlap, 14 didn't decline, and 0 out of 14 had overlap. So there is some utility to what they're doing. We have been using a block design task, courtesy of my graduate school mentor, Susan Buchheimer, who's sitting in the room. I went to her and I said, we need a task that maximally taps the hippocampus in a short amount of time. And she said, we'll try this. This was working well for us. So it's a block design with a learning trial, a distraction trial, X's and O's, and then a recall trial, and I'm going to talk about that. 7 word pairs and 6 blocks. We've been seeing really nice hippocampal, perihippocampal activation during this task, but one thing that's always bothered me is that for this, they're actually supposed to push a button if they're sure they remember it. And that works pretty well for adults. For kids, that's been tricky. We don't worry about it too much because we give them a separate set of 7 word pairs before they go in, and we use that as their learning curve. But I always wanted to try to figure out a way to have them talk in the scanner. So I think I see some NIH people here. I scan primarily at the NIH, or I did prior to COVID. And so we worked a lot with the multi-echo sequence. I can go over all of this, I won't have time to do it, but I primarily wanted it because it's good for denoising. So I could try to have them talk in the scanner and then use the properties of it to denoise after. And it did not disappoint. So in 2 subjects that I have here, these are just single subjects, we have the single echo and then the multi-echo for these same people with that paired learning task, word learning task. And you can see there's much stronger left hippocampal activation during the multi-echo in the same person than in the single echo. And then what I thought was super exciting was that because they're talking in the scanner, you actually also, with the multi-echo, pull out the language network very, very nicely. So it could be kind of a 2-for-1 task. I will say this work is not used clinically at this point, but we hope that it might be at some point, so I'm bringing it up quickly. We're doing something called connectopic mapping, which some of you in the room are probably familiar with. I don't have time to go over it, but I will do that at the end if anyone's interested. We want to know how the hippocampus is connected to the rest of the cortex to see about the implications for surgery. We know in adults that there's a primary gradient anterior to posterior in the hippocampus. This had not been done in kids. We wanted to see if it was related to memory in kids. So we published this in PNAS in 2024. And we found that the gradient was very similar in kids, both in the HCPD and NKI sample, similar to adults anterior to posterior. And it did predict episodic memory, and what we thought was super cool is that across age, it's actually pulling apart. So the anterior is hanging more together, and the posterior is hanging more together as people age. Okay, quickly. We also can do cognitive mapping with subdural grids and SEEG. It's very, very similar. So you do a grid placement or a depth electrode placement for SEEG. You create a task selection, you do baseline testing, and then you do electrical stimulation. This is a grid for those that haven't seen it. And basically what we do, we decide the assessment material, we do baseline testing, items that are easy and that have a fast response, usually less than 2 seconds. They name pictures, they have auditory responsive naming. That's what we do at our hospital. Lots of hospitals have different protocols. And then in the room, you're actually with a neurologist who's stimulating and keeping track of the context, and then I'm a neuropsychologist. I present the items and usually keep track of the errors, and at the end you have a map of where there's impairment or no impairment, and you can do a similar thing with SEEG. So this is a patient with SEEG. The only difference now is that instead of a grid, you have a depth that's implanted, and you also can do some passive mapping, which I'll talk a little bit about. But this is what it might look like with the plan from the surgeon. And like so this person has 6 electrodes. These are the paths, so it's not just, it's everything it's hitting along the way. We're highlighting C and E here. So you could see for this C going temporal pole, E going fusiform to inferior temporal gyrus, what we might give for that. So for C, for temporal pole, we might give a picture naming task. For E, for fusiform, we might do facial recognition. We're often pulling from our neuropsych tests for this, but also some homegrown things. You can also do the passive, so you can do this with stimulation, as I said, and you can do passive mapping as well, which is just measuring the electrical activity. Okay, so I hope I've convinced you that these guides are necessary to predict and minimize adverse impact of surgery on cognitive functioning. We can use language and memory fMRI, subdural grids, SEEG, but we have to factor in age, cognitive ability, and bilingualism when thinking about these things. Thank you to all the families that have participated and my team, and we'll take questions at the end.